Hi, my name is Alberto Peralta, and I am going to present this paper on governance and other drivers that affect the networks that are created in the public sector for innovation, in particular health services. I should be there with you, but unfortunately, my airline company decided to do something else, and although I have been in here in Seattle for the last 3 days, 4 days, uh, they decided that I should change my schedule and well, left me without any other chances of addressing you except this video. So I really apologize for this because this wasn't the intended way that I should be presenting this paper. I, in any case, appreciate your time, and I hope that this brief video will, to some extent, replace the presentation that was going to be taken live today. A bit of myself. I am a PhD in economics and business administration, concentrating on two main fields: business model innovation and public sector innovation. The goal of this research is to theorize in a framework that can help us understand what is going on with what we have called public service innovation networks. That means the networks that are created in the public sector for their innovations. We want to base our research on three dimensions: social characteristics, multiple actors, and functioning mode. I'll expand on a bit on all of them. I don't want to make the video too long, but what we want is to have a comprehensive approach that is based on a specific technique, research technique, partial least squares, on social model equations, and run an empirical experiment to let us know which of those dimensions are relevant when a public entity, a public agency, puts together several actors to develop their service innovations. In this sense, probably would be beyond our research goal. Could be interesting to have what is one of our main research questions, because this is an ongoing research project. So in this case, we ask which are the conceptual dimensions of these health associations that are called public service innovation networks, what we call PSINs, to make it shorter. This research is based on the idea that, well, probably the pandemic made relevant that, particularly in the health sector, there are certain innovations, I would say most of the innovations, that are involving several actors, and that technical and non-technical innovations happen at the same time, and probably they're indistinguishable. So some innovations are developed top-down, conventionally, and others are created bottom-up. And but in any case, top-down or bottom-up, it is easy to see that there is more to the innovation than just the product innovation or the process innovation, right? So basically, we acknowledged that there are implications far beyond the mere product responsiveness or effectiveness in solving a certain need, or the mere process in attending a patient's needs. There are other elements that aggregate, whether it's, like I said, efficacy, implementation, governance, organizational impact, quality, fairness, equity, accessibility, and other, well, social and even environmental impacts or conditions that these networks and public administrations realize that happen when they are trying to innovate their services. It is usually understood that health innovations are supplier driven, whereas what we have seen a combination of those through the pandemic, but probably what is more relevant is how the collective and interactions that happen between suppliers, health institutions, hospitals, and so on, and the general public and even public administrations that have nothing to do with health, have joined forces and have created these large or small networks to design and implement new services. And this is nothing new. The pandemic probably highlighted those connections, but this is something that has been in the making for quite some time, and what we have also acknowledged as a research team is that we don't have an understanding of how these innovation patterns happen when the actor developing those, designing and implementing those innovations, service innovations, happen to be a network. This is another way of saying that we want to analyze how health innovation happens in today's multi-agent context. And this means that the context puts together a combination of technical and non-technical characteristics and agents that is what really underpins our research and what we're interested in knowing, as you can see in our research question. Why we believe that this matters? We believe that networks integrate multi-level and cross-border settings. That means that policy and decision-making is not as easy as it was or as it is in top-down organizations. When you have multi-levels and when you have these different interactions, the associations between the agents collaborating together, the parts that form the network, it is probably something that poses a challenge or a big challenge to conventional decision makers and policy makers. So particularly these interactions happen not only between the actors, local actors, but also with even regional, national, and multinational connections that end up in potential new services or approaches to conventional services. In this context, decision makers have trouble with the governance and the meta governance of these networks. That means that public managers, politicians, decision makers particularly those aiming for democratic legitimacy, efficiency, effectiveness, trust, and reputation, they see that there is an unconventional way of governing these institutions, and probably they lack the elements that they can use, the levers they can use to create or to manage and lead these organizations. This I wouldn't say amorphous, but rather borderless type of organizations as the networks for health innovation, for health innovations or health service innovations. Again, the literature offers little assistance on this, and what we believe is that we needed to have or to give at least an answer to these concerns. I would like to raise your attention to the model that we are working with. Again, 3 dimensions: actors dimensions, functioning modes dimensions, a dimension, and social dimension. All of them aggregate in this matrix, and we have considered them as these dimensions. We have considered them as vectors. Each of the elements of each of the vectors representing a different agent with different characteristics. So basically, these dimensions are constructs, are aggregations of characteristics that define each of the, in this case, for example, first vector, actors dimension, of each of the actors. So in a way, this is a multi-dimensional, multi-level model that in this case, in the representation that you have here in this first graph figure, integrates technicalities with human choices, social and civic characteristics, and competencies, and environmental circumstances that we believe produce the service innovation. We and the literature believe that produce those elements, those innovations. Now, conventionally speaking, these elements were not these, were limited only to the material, technical elements. So what we are approaching is this formation of the networks, that we call PECINs, as a combination, as you can see, of technical systems and technologies, if you wish, with other elements that the characteristics based approach poses as potentially relevant. This is important because the potential technical innovations, the potential innovations that these networks create, we believe, and again, following the characteristics-based approach, are combinations of technical and non-technical innovations. So we assume what is called a synthetic or integrative stance towards defining what could be the antecedents of how the networks create innovations, and that integrative or synthetic approach or stance help us go over the traditional boundaries, for example, in terms of recruitment or in terms of other elements, other policies, other decisions that could be taking place. I spoke of recruitment, but it could be expenditure or resource allocation or resource substitution. Again, decisions or policies. Okay, these networks then, based on this figure, stand as collaborative arrangements of actors, as you can see in the actors dimension, but also technical and non-technical elements that are not only interacting dynamically, it is also and this is something that we believe there's a mutual dependence, obviously between the actors, but also between these actors and the other vectors. That's why we create the matrix, and that's what, in our opinion, creates the network. That dependence, that mutual dependence. Okay. What then the figure represents, and this is the probably what matters, is that there is an intra-organizational level within the network that is defined by these vectors, but by these dimensions, and they basically speak of mediums and functions or operations. That's the what the social vector represents. So the operations that the networks do, or the relevant functions that this network or the networks perform. The organization types and organizational elements that are comprised in the functioning mode, and the typology and competences of the partners or agents or the actors, which is the actors dimension. Now there's a further interorganizational level which transcends the PECIN, the network, and is what the network at the end produces, and how it connects, integrate, how the networks integrate in the wider ecosystems. We haven't studied the ecosystems. We just stopped in the innovation types and innovation outcomes vector, matrix that you have in this figure. We have considered different types of innovations, rather, I mean, either technical or non-technical. I'll go into that very quickly, but also outcomes, time, user experience, satisfaction, quality, outcomes. In relationship with the types of innovations that we have controlled for, we have technical, non-technical, plan, unplanned. We have systematic, non-systematic. We have strategy or policy, product, service, process innovations. We have a clear, very well-defined solutions, and or adopted or original innovations, or radical and incremental innovations. So we have tried to control all sorts of potential outputs and outcomes from a conventional health institution to check with which of all these networks are correlating better. This next then is our research model. You have the intra-organization and the on the left, and you have the outer or the inter-organizational level or connection on your right. Although I don't want to go into the details of the hypothesis, but we created like I said before, using PLS, we created a model that connects the dimensions here in social actors and functioning mode that you can see as grayed in the cases of social and actors, and in white here at the bottom here as the last dimension, all impacting in our Piscines construct. And as you can see, the 3 dimensions are built of several elements, characteristics that aggregate into each of the dimensions, each of the main constructs of the research. This is more than 100 variables that we have put together in the whole research model, and well, this is a complex network. I mean, a complex research that initiates, we believe, this type of analysis, and in any case, static analysis. Very quickly, I'll go into the final part of the presentation, because okay. Now this is our sample. We have 253 participants, and we were comparing health and non-health. As you can see, the health networks, sorry, participants in health networks were a very small subsample of the whole one. So that's why we believe that our results are initiate this type of analysis, but obviously cannot be conclusive enough. Although the elements that we have tested and the strength of PLS to test small samples, they are well defined, and given that there's consistency and relevance, can be extended or need to be extended in any case. We had these contributions first out of the 114 characteristics that we have controlled for. Only 37 in the case of networks in general were relevant, and only 18 were relevant for the health segment. So this means that there is the theory explains or presents many characteristics that then reality may not be explaining, may not be agreeing with. And with those characteristics, that are relevant is obviously with what we have built our dimensions. Out of the dimensions, social is the strongest, and then social is the strongest, I was saying, and then the functioning mode also shapes health networks. What strikes is that the actors element, the actors dimension, is far weaker than we expected, and that means that probably the impact it is still relevant, but it's weaker. So it's the weakest of the other of the three dimensions. When one could think that a network is mostly influenced, and its impact on, in this case, innovations and outcomes may be influenced by the type of actors that are integrating the network. What we have seen is that this may not be that relevant, or this may be secondary to the type of elements, the type of engagements that these actors have, the type of techniques that they use to produce those outcomes or those innovations, the type of engagement that they have, and elements like trust or the ways that they function together within the once the engagement is confirmed by those actors participating in the network. So those elements are relevant. Again, just to briefly refer back to the idea of our study is willing to provide the elements that will help govern, meta-govern these networks. So we're trying to set up a reduced or a large, in this case reduced, set of elements, if you want, KPIs to control for, in the case of identifying how networks produce their innovations and outcomes in the health sector. We provide then empirical evidence of the positive correlation of these networks with non-technical features mostly. So out of those social and functional mode, what is relevant is that it is more meaningful to consider the non-technical aspects in the intra-organizational part, and that the type of innovations that these networks create are a combination and mostly leaning towards non-technical innovations and outcomes than to technical innovations. But this has a ditch. So in this case, networks are more than a mere production function or an aggregation or of medical and well, IS technologies, information systems technologies. So it is the peripheral or service activities with multiple actors and context characteristics that that really form the networks, which was in any case expected. What was unexpected is that the social and functional mode were more relevant than the actors dimension. Again, speaking theoretically. This probably supports the synthesis or integration perspective, integrationist perspective, if you wish, and how health networks correlate with, and then we go for the inter-organizational part, non-technical and ad hoc types of innovations. And that means that they probably are more on the mindset, idea, organizational strategy, and policy innovations, and they may be used for that, particularly from a theory perspective, from a theoretical perspective. Now, from a theoretical contribution, from a theoretical perspective, Also, and this probably might be unexpected, the more mature the network, the more limited the innovation types that the network produce. This means that there is a negative relationship between their life cycles stages and the types, the extent or scope of innovations that the networks concentrate on. The more, the younger the network, the more disruptive. The older the network, the more conventional or classic type of innovations. Okay, there are certain analyses that we reflected on that you have in the paper, but these are the main ideas. From from a practical perspective, again, this element of the life cycle and how the innovations differ in terms of novelty. Also, health networks aggregate peripheral and service activities instead of those that are only connected with diagnosis or treatment functions. This is important because the networks not only work with diagnosis and treatment functions, which are the typical functions of health institutions and health agents, but also integrate some other that are more connected to the service and service activities. Okay, so in this sense, we have identified groups of operations that bring together material objects, like again diagnostics and or other operations, with information knowledge, with individuals, all put together. That obviously and unsurprisingly, asks for partners whose abilities are a combination of non-technical and technical, leaning towards the non-technical abilities. Okay, which is also consistent with the theoretical foundations of our model. Finally, our research uncovered unintentional, or what we have perverse competencies. That means unintentional because they were competencies that the theory, past theory, acknowledged as relevant, but we have seen that they are not relevant, at least in our sample and in our research. These particular characteristics, and well, to some extent, they could be, and that's the perversity here, that they are not there, that they don't happen, that we weren't able to register them as meaningful. That doesn't mean that they are not desired. That's the perversity. So basically, functions like how the network understands how users and citizens engage with the PSIN, with the network, and in the network, with and in the network, how to improve equity and inclusion, how to improve fairness and balance, if that's a goal, that we improve equity, and inclusion doesn't mean that the network should be fairly represented or balanced represented. But in any case, those are elements that have been proposed by the literature and are not. We haven't seen them in our at least in our sample. And that's it. Hope it was relevant and that you like it. And please send me any questions. You have there my email. Please, and I'll be very happy to share the paper in its actual shape and to answer any questions if you're interested. Thank you very much.